Dear colleagues, dear friends, thank you very much for the invitation to the organizing committee to address this topic. So we're referring to the complications referring to the epicardial ruptures because coiling is related to that. I'm going to present you a case just as a trigger, and then I will discuss a little bit of some aspects of coiling. This gentleman, 56 years old, that with risk factors of diabetes, hypertension, hypercholesterolemia, and a smoker. In the past, he is known to have coronary artery disease within the PTC and the RCA. He had an aggravation of his angina pectoris. Positive test was performed, and an angiogram showed that he hadn't occluded any more right coronary artery and diffuse instant stenosis in the stents in the distal part. You can see the angiogram here. This is not the diagnostic angiogram, but this is the planned PCI. You see a left system, diffusely diseased, but with not any very significant problems. There are collaterals to the right. The lesion is relatively short. You see the diffuse disease. It was at the rest antegratally. You see here a guy, a second wire supported by a fine cross microcatheter. The crossing was nothing of relevance to the case. And after some predilatation of the proximal cap, a dual lumen microcatheter was used, and you see here you take access to the distal to the posterolateral branch. So I would like to bring to your attention, you see a wire here, which is a wire of the PDA, goes around the apex and enters the LAD. It was just an incident happened, the wire just went through. You see here the wiring of the PLA, kissing balloon post-dilatation, and more or less the procedure looks like that, at least from the CTO part, it's finishing, and you just want to do optimization. It was not very easy to advance materials there. So during the procedure, we struggled to bring materials down. And when you push things, you know, the wires go on going in and out. And suddenly, without very much attention, there was an epicardial collateral from the LCX. You can see it here. It was not very visible in the angiogram, but the wire from the PLA, it reached this collateral, as you can appreciate. And at a certain point, you can see the epicardial collateral course and the course of the wire. So the wire is a little bit not in full alignment in crossing close to the circumflex. Anyway, to make a long story short, this careless evolution of the case led to a perforation of this epicardial collateral was completely unnecessary. And clearly, after the restoration of the antegrade flow, you see the epicardial collateral from the PLA, and it goes all the way to the proximal circumflex. We were finishing the intervention in the distal. I said, let's see what is going on. We did the procedure for the right coronary artery, but clearly this perforation wasn't going into the right direction. The vessel was getting bigger and bigger. The perforation, hematoma, whatever you can call it, at this time point, you see that there is no any pericardial effusion, which is visible. But due to the evolution of the case, we decided that we will do something about that. You see a microcatheter, a fine cross, which is the same microcatheter that we used for the to perform the CTO was used, and coils are coming. I'm going to talk to you about that. But you see the delivery of coils via, this is the Azure coils from Terumo, are going through a 0.14 wire microcatheter. The first coil is being delivered, as you can appreciate here. These were pushable coils in this case. That's the detachment of it. Okay, and then we assess the situation, and it's obviously that there is flow again going on. And for that reason, from this side, a second coil, the same aspect was performed. There you can see it was shorter than the first one. And then it looks like that from one side, there is the flow of this collateral to the perforation side is getting less, but it is obvious that there is a field communication from the other side, and you see the same microcatheter ones from the left side now. You make the tip injection in the collateral from the left side, you can see it here. And of course, it is absolutely necessary to isolate the perforation side from both entry points of this, both from the left and the right side. So another coil of the same type has been again placed. And you see that after that, the flow and the tension within the perforated side has been reducing over time. This took some time, and you can clearly see, I believe, that there is a pericardial effusion now in this patient. So the procedure was being concluded by tapping, as you can appreciate here. And then the patient had an uneventful recovery. It was a complete sealing, and it was solved without the necessity to do any other thing. So you saw a case of how these things can go. In this case, it was from carelessness in a procedure that has been finished. I will just go through a very recent publication, not to say more. This is a publication from the Progress CTO score from the United States, which I have the opportunity to review and write an editorial about that. And you find here which are the parameters that they are increasing the risk for perforations. But what is the most important thing of all of that is that you see that what are the most relevant perforation, at least for the coilings, are the epicardial collaterals, where you see a coiling rate of 18%. And of course, distal vessel ruptures that you see a coiling of another 18%. But when you have large vessel perforations, coils are not relevant. And I think that over there, the cover stents are playing an important role, as also what is happening in other vessels. What is very important to understand is that you see that distal vessel perforation and epicardial collateral are accounting almost for 40% of all perforation that happens into during CTO interventions. And from this 40%, you need a little bit of close to 10% of coiling. So it's not something that is not relevant. And you should know that the perforations in the CTO is 5%, around 60%. The complications are around 64%, 60% are related to perforations. So as far as the numbers are increasing, it becomes relevant. So if you do around 200 CTO PCI per year, and you do around 30% retrogrades or whatever, you would expect that you will coil 3-4 patients. And that's finally something that, because for these kind of complications, there are no other solutions. To come to the final part of this presentation, I will not get into the very details of all the coils. I just took the opportunity to tell you a few things that are, when we're talking for coils, the way that you need to know the things that you need to know. First of all, is that how you push them. So you need to be familiar with certain coils. There are coils that they're detachable. That means that you put a device in the back of the coil after you put them into the coronaries, and then you press a button, and then this releases with different types of mechanisms the coil. And there are coils that are pushable. So essentially you take them and you push them, whether it's depending on the size with even your guide wire, or they have special pushers by themselves. So that's the first information that you have to ask. The second information that is very relevant is what kind of microcatheter is compatible with your coil. So, and as you can appreciate here, there are coils that are 0.18 that they go through very small microcatheters. These are usually neurocoils. And there are coils that are for other reasons, for peripheral vessels, 0.35. So first of all, you have to have the appropriate material, the way that they're detaching, and what kind of microcatheters you need in order to be able to deliver them. You see here some few of them, and that's my last slide. And referring to the small vessel closure, these three coils are neurocoils also, but these are the coils that they can go through the microcatheters that we're using for coronary interventions in the majority of the times, or interventions at least that they're relating to the procedure of CTOs, which are usually small lumen microcatheters. But in case that for some reason you don't have them, essentially you have to open a new microcatheter. The coils, sometimes they come compatible. They give you the guidance of which microcatheter can be delivered, and then essentially, if they're not compatible, what you already have, you have to get the expense of a second microcatheter and deliver them. So these are the very basic principles. For something that it doesn't happen very often, but when it happens, there is no other solutions. Of course, not other, but because you can inject through microcatheters fat, you can inject microspheres. There are other things that you can do, but certainly you have to be familiar with coils and how to use them.